Good afternoon, everyone. Good afternoon. So, in this session, we'll be discussing the high-yield topics of the biochemistry, and we'll try to cover the confusing aspects and the concepts of the biochemistry. At the same time, we'll also discuss that how we should read the question so that we can avoid the silly mistakes and how we should approach towards the context of the question, that what the examiner is really willing to ask to us. So coming to the first question, whenever we see a question, one of the first thing that obviously will come to in our mind is because of the, the peripheral field of vision, we will see the options also at the same time, even without reading the option. So the moment I will read, I will see these options: alpha 1,6, alpha beta 1,6, and all these things. The carbohydrate chapter is going on. The branches asking about. So a researcher is studying is hepatic glycogen architecture, and notes that the enzymatic removal of a specific bond leads to loss of the branch point. Loss of the branch point. Now, what we know about the glycogen structure is, in the glycogen structure, we have a base that is called as the glycogenin, which is made up of a protein. And then we have the glucose residues. These are the UDP glucose molecules, which we attach in the linear sequence. First, we make a linear sequence like this. The glucose will attach around 11 glucose molecules like this. And the direction of the bond, which is going to be here, is alpha 1, alpha 4. The glucose molecules are in the alpha state. So alpha 1, the first carbon uniting with the 4 carbon. Then once we attach the 11 glucose molecule, then we'll make the branch. And this branch that will be made, it will be in the direction of alpha 1, 6. Alpha 1, alpha 6. Alpha 1, alpha 6 glycosidic bond. And then again, we have the linear sequence. And once we have the linear sequence, it is alpha 1, alpha 4. So what they're asking is that we have an enzymatic removal of a specific bond leads to loss of branch. The branches are not there. So which type of glycosidic linkage is selectively removed? Means we have removed this particular thing, and removed this particular thing means we have removed the alpha 1, alpha 6 glycosidic linkage. Now, why and what are the other points that you should remember about from the glycogen is, whenever we have the extra glucose, when we are in the fat state, we have so much of glucose molecule in our intestine, we join them together and we make the glycogen. And the rate limiting enzyme for the glycogen synthesis is going to be the glycogen synthase. And to make the branch, we require the branching enzyme. So the two important enzymes during the glycogen synthesis, it is the glycogen synthase and the branching enzyme. So the researchers actually has removed the activity of the branching enzyme. So alpha 1, alpha 6 linkage will not be there. The second question is, it is related with the GLUT transporter. Which transporter is affected? A 6-year-old child develops abdominal distension, osmotic diarrhea after ingestion of fruit juice. The moment I will read this much, I understood that it is going towards fructose intolerance. The child is not able to tolerate the fructose. Now, what happens in the fructose intolerance is basically when we consume the fruits, that is the fructose, normally these fructose molecules are absorbed with the help of the GLUT5. In the intestine, we have the GLUT5, and we absorb it and we send it to the blood. From the blood, this will go all the way to the liver, and then further the metabolism will be affected, will be happening. So they're asking that key, this patient is, whenever he's consuming fruits, he's not able to tolerate that. If the fructose molecules are supposed to be absorbed here, then it is supposed to go inside, and then the further fructose metabolism is happening. They're asking that the defect of most likely involves the apical transport of a monosaccharide by the sodium independent facilitative transport. The moment they say sodium independent, so this cannot be the answer for sure, because this is a sodium dependent transporter. They're asking that which transporter may be affected in this case. It can be the effect of the GLUT5. Because if the GLUT5 will distension, flatulence, plus this fructose will be coming in the stool, that will lead to osmotic diarrhea. So basically, they're asking, initially, it was looking that as if this question is going towards fructose intolerance, but later on, they have said that which fructose transporter is affected and can produce the similar symptoms, it is the GLUT5 effect. The GLUT5 is the fructose transporter in the intestine. If you see the other ones, the GLUT1, it is found in the RBC. GLUT2, it is found in the beta cells of the pancreas, as well as it is found in the basolateral side of the intestine. And this is for the glucose transporter, not for the fructose transport. For the fructose transport in the intestine, we have the GLUT5. The next is, in the glycolysis, most regulatory reactions are irreversible due to large negative free energy changes. However, the certain step operates near equilibrium and readily reversible under physiological condition. Which of the following is near the equilibrium? Means which of the following is the reversible one? So this is more of the language playing that is happening. You should be knowing that which reactions are irreversible, which is reversible. So in glycolysis, we convert the glucose into pyruvate. There are going to be total 10 steps. Out of 10 steps, three are irreversible and 7 steps are reversible. So they're asking that which is the reversible. Irreversible one, we have three. That is the first one, the last one, and the rate limiting one. First, last, and the rate limiting one. The first one is the hexokinase, the last one is the pyruvate kinase, and the rate limiting step is the PFK1. So the reversible one is going to be the remaining answer, that is going to be the enolase. It is a reversible reaction. First, last, and the rate limiting is the irreversible one. So it's a pure language playing. That is, if I would have asked this question in a simple line also, which of the following is a reversible step? This is what these 4 lines are trying to tell you. The next is a 24-year-old male presents with the chronic hemolytic anemia. The peripheral smears are showing the echinocytes. There is elevated indirect bilirubin. Yes, it happens in the whenever there is hemolytic anemia happens, there is going to be increase in the unconjugated bilirubin. There is going to be increase in the LDH2. That is bound to happen in any hemolytic anemia. This is bound to happen. What they additionally said that in the RBC, the ATP levels are very much reduced. The moment they say the RBC ATPs are not having, see, the only source of energy for the RBC is glycolysis. Glucose converts glucose converts into pyruvate, pyruvate converts into lactic acid. This is what is happening in the glycolysis. And one of the key enzyme which is generating the energy in the glycolysis is the pyruvate kinase, which gives us the 2 ATP, which is actually the net benefit of the entire glycolysis, glucose till lactic acid. The net benefit of 2 ATPs is there, and that is coming from the enzyme pyruvate kinase. If the pyruvate kinase enzyme is not there, the RBC cannot survive since they will not be having the energy. So this is what they have mentioned, that the RBCs are having the reduced level of ATP. The moment they said that, we understood that there is a problem in the glycolysis that is going on, and the name of that enzyme is going to be pyruvate kinase. Now, why the others cannot be the answer? Because see, hexokinase does not give you the ATP. Rather, we invest the ATP. Phosphofructokinase also, we invest the ATP, does not give the ATP. Enolase, there is no energy reaction that is happening in the enolase. So the answer is going to be pyruvate kinase. See, in biochemistry, whenever they talk about hemolytic anemia, there are 2 enzymes that should definitely come to your mind. One, it can be a pyruvate kinase deficiency, or it can be G6PD deficiency. Now, how to differentiate them? In both of hemolysis is happening. In both of them, there's going to be increase in the unconjugated bilirubin. In both of them, there's going to be increase in the LDH2. The main difference is going to be the trigger. In pyruvate kinase deficiency, the ATPs are not there. So the anemia is going to be kind of chronic anemias. It's going to be chronic anemia. Whereas in G6PD, it is going to be episodic anemia. Whenever the patient will develop the free radical, he will have this problem. The G6PD is going to be episodic anemia after taking certain drugs or after having the infection. There is a anemia is happening, then it is going towards G6PD. And here they have clearly mentioned that this patient is having a chronic hemolytic anemia. So that is going towards pyruvate kinase deficiency. The next was during the prolonged fasting, the hepatic glycogen contributes to maintain the blood glucose level. Yes, during the fasting state in the liver, we have the glycogen, which will cut, and ultimately we are going to make the glucose. And these glucose molecules will be coming in the blood and maintaining the blood glucose level. So in the fasting state, we don't go into hypoglycemia because of this pathway. Whereas the skeletal muscles, glycogen does not able to do that. Actually, what happens is in the skeletal muscles, when you cut the glycogen, here is the muscle. The last product, when you cut the glycogen, actually you cut, and you make the glucose 6-phosphate. Here also, when you are cutting the glycogen, you come till glucose 6-phosphate. To convert the glucose 6-phosphate into glucose, you require the enzyme glucose 6-phosphatase. And this enzyme is found in the liver, but this enzyme is not found in the muscle. So the muscle is not able to convert the glucose 6 phosphate further. So this glucose 6 phosphate will undergo glycolysis and will give energy to the muscle. Whereas in the liver, the glycogen can convert into glucose and that can come in the blood and that can maintain the blood glucose level. So they're asking that the difference is due to absence of which enzyme is not found in the muscles, which is found in the liver, that is the glucose 6 phosphatase. Now, can you tell me that glucose 6 phosphatase deficiency, if it is there in the liver, by chance, if this enzyme is not there in the liver, then which disease will happen? If the glucose 6 phosphatase is deficit, then in the fasting state, the liver will not be able to make the glucose and the patient will develop severe hypoglycemia. There's going to be severe fasting hypoglycemia, and that is this disease is referred as what? This disease is referred as the von Gierke disease. That is the type 1 glycogen storage disease. Type 1 glycogen storage disease. Can you tell me one more disease of glycogen storage which can lead to hypoglycemia, where you are not able to cut the glycogen nicely? There is one more disease if the debranching enzyme is not there. If there is a debranching enzyme deficiency, that is called as which disease? That is the Cori disease. In that also we will have the hypoglycemia, but this is going to be a mild hypoglycemia. It's not going to be that severe hypoglycemia like von Gierke. That is one difference. And one important difference is in the Cori disease, because the debranching enzyme is not there. So when you are going to do the liver biopsy, which type of glycogens will be there in the liver? Because the debranching enzyme is not there. So when you will do the liver biopsy, which type of glycogens will be there? Unbranched glycogen, short branch glycogens, which things will be there? We are going to have the short branch glycogens will be there. And this Cori disease is also referred as the limit dextrinosis, because the limit dextrins are accumulating in the liver, so called as limit dextrinosis. A 4-month-old infant with the poor feeding, progressive difficult holding in the head means there is some problem with the muscles are going on. The parents reports there is reduced in the activity, there is rapid breathing over the past few weeks. There is marked hypotonia. The muscles are very flaccid. There is hepatomegaly, sign of heart failure is there. See, I always see in my class that whenever you see a cardiac problem happening in the child in a question of biochemistry, you should, one of the things that should come in your mind is Pompe disease. We say that heart failure means pump failure. The moment you see pump failure in biochemistry, you should think of Pompe. Although I am not as of now confirmed, but I am thinking of Pompe disease. Then they have said that there was some cardiomyopathy was going on. The muscle biopsy have shown below. There are some molecules. If you see these white things that is accumulating, these are the glycogen molecules which are accumulating in the muscles. What is the most appropriate therapeutic intervention? This patient is having Pompe disease. What is happening in Pompe is, for example, here is the muscle. The glycogen molecules mostly are going to cut down in the cytoplasm of the muscle, no problem. And we make the glucose 6 phosphate. But some molecules of glycogen goes inside the lysosomes. And in the lysosome, we have one enzyme called as the acid maltase. And that is going to cut the glycogen molecules inside the lysosome. If the acid maltase enzyme is not there, then the glycogen molecules will accumulate in the lysosomes and will damage the lysosomes, that in turns will damage the muscles. So how to treat this patient? We need to do the enzyme replacement and we have to give this acid maltase enzyme. So what is the treatment? High protein diet? No, nothing to do with the protein here. Liver transplant? No, there is no problem with the liver. It's a muscle problem. Should we give the recombinant lysosomal enzymes? Yes, we should do the lysosomal enzyme replacement. And basically, which enzymes is to be replaced is the acid maltase. We want to replace the acid maltase. Right. The next was, although this particular question we have tried to remember in the class as a fact also, right? But let's see the same thing in the concept manner. They are saying said, a patient with hepatic encephalopathy develops cerebral edema and reduced neuronal ATPs. There is excessive ammonia is there in the brain, and that drives the increase of the glutamine formation from the glutamine. Now, the progressive depletion of which TCA cycle intermediate contributes most directly to impaired oxidative metabolism. So it's a pure and pure. It is pure and pure uh, the language of the question which the examiner is trying to play with you. The things is very simple. They are saying that whenever there is hyperammonia, how it is going to stop the Krebs cycle. How hyperammonia stops Krebs cycle. Which intermediate of the Krebs cycle will be depleted? This is what they're asking. Now, what happens is actually they said that hepatic encephalopathy is going on. Those who are having cirrhosis, the ammonia is supposed to convert into urea, and that happens in the liver. But now the patient is having cirrhosis, so the ammonia is going to increase. He cannot convert into urea because the liver is not working. Now, this ammonia molecules will reach all the way to the brain. Once the ammonia reaches to the brain, they are going to be trapped in the astrocytes. In the astrocytes, they are going to be trapped by the glutamate. And they are going to make the molecule glutamine. Actually, we are trying to send these glutamine molecules, and we want to give it back. We want to send it out. But the problem is the ammonia is coming so and so much that there is going to be a lot of glutamine formation will happen, and that is going to pull a lot of water, and that will lead to cell edema. The more the cell edema, the more the problem is happening. So what happens is, whenever there is more ammonia is reaching to the brain, there is more glutamate consumption happens. The glutamate is consumed more and more to make the glutamine. We also know that glutamine is the transporter of the ammonia. So we can say that whenever the ammonia goes to the brain, we require excessive glutamate so that we can make the glutamine and we can throw it out. But from where I will get this excess glutamate? From where I can get the glutamate? There is one reaction where we have discussed the formation of the glutamate. There are different amino acids we can convert into glutamate. And to convert the different amino acid into glutamate, this reaction is called as transamination. The enzyme of the transamination we have discussed is, for example, alanine transaminase, aspartate transaminase, where you are converting the alanine into glutamate, aspartate into glutamate. That is alanine transaminase, aspartate transaminase, which we also called as the SGPT, SGOT. Now, how the transamination reaction was actually happening? To convert the different amino acid into glutamate, actually we require, apart from the enzymes, we require one more thing, that is alpha ketoglutarate. So I can say that if you require more glutamate, which is happening, if there is a hepatic encephalopathy, we want more glutamate in the brain. If I want to make more glutamate, I need to do this reaction more and more. If I want to do this reaction more and more, I require alpha ketoglutarate. And from where I can get the alpha ketoglutarate, it is from the Krebs cycle. Because alpha ketoglutarate is an intermediate of Krebs cycle. So I can say that whenever there is hyperammonia, the brain, what it will do is, from the Krebs cycle, it will take out the alpha ketoglutarate, it will mix with the amino acid, will make the glutamate so that we can send out the ammonia. So the alpha ketoglutarate is going to be depleted. This is what is happening. They are saying that the hyperammonia is going to stop the Krebs cycle by depleting which intermediate? It is the alpha ketoglutarate. I want you to remember this direct as a fact also, that hyperammonia stops the Krebs cycle by depleting which intermediate. Even if you see the workbook, we have written that as a direct statement. Hyperammonia stops the Krebs cycle by depleting the alpha ketoglutarate. We have written that in the summary. Now, this was an easy question, right? The moment you will see this image, you will immediately think of Pellagra. That is B3 deficiency. This is the castle necklace appearance that is going on. Now they're asking that deficiency of which of the following substance is most directly responsible for this presentation. So they are saying that there is the B3 deficiency is going on, but when I looked at the options were amino acids, not the vitamins. Actually, the B3 is made by which amino acid? It is the tryptophan. So if there is a tryptophan deficiency, there will be B3 deficiency, and that will lead to pellagra. So the direct deficiency of tryptophan will be there. Now, can you tell me that what is the first symptom of pellagra? What is the first symptom of pellagra? Is it diarrhea or dermatitis? What is the first thing that is going to be there? The first is going to be diarrhea. Then there is going to be dermatitis. That is going to be the castle necklace appearance. Can you tell me one more thing, that pellagra is due to vitamin B3 deficiency that we understood. To make the B3, we take the tryptophan and we convert into B3. But this conversion requires one more vitamin. Can you tell me which vitamin is required? That very good, B6. To convert the tryptophan into B3, we require B6. So I can say that to make the B3, we require B6 also. And what is the name of this pathway? To convert the tryptophan into B3, this is called as the kynurenine pathway. It's called as the kynurenine pathway. The rate limiting enzyme of the kynurenine pathway, it is going to be quinolinate phosphoribosyl transferase. Quinolinate phosphoribosyl transferase. Right. A public health program implemented in the universal newborn screening using dried blood spots to detect multiple inherited metabolic disorders simultaneously. Now, which investigation allow you to multiplex detection of the amino acid and the acyl carnitines in a single assay? Actually, now let's look at the options. See, Southern blot, we know that it is done to find a specific DNA. If you want to find a specific DNA, you will do the Southern blot. Tandem mass spectrometry will tell you the different levels of the amino acids and different levels of the metabolites in the blood sample. That which amino acid is more, which amino acid is less, what is the concentration. For that, we do tandem mass. Polymerase chain reaction, it is done for the DNA amplification. If we are having a copy of DNA and you want to make multiple copies. Agarose gel electrophoresis, it is used for the segregation of the proteins or DNA or whatever segregation that you want to do. For that, you can use the electrophoresis. Now, what they're asking is that which test can be used on the blood spots to detect the multiple metabolic disorder. For example, one of the metabolic disorder is phenylketonuria. Now, what happens in phenylketonuria? That the phenylalanine is supposed to convert into tyrosine, but this conversion is not happening. This is called as phenylketonuria. In that case, the phenylalanine will be more and tyrosine will be less. In the same way, we have discussed many diseases. For example, we have discussed about alkaptonuria. What happens in alkaptonuria is homogenetic acid is supposed to convert into mallyl acetoacetate. If you remember, hum gaate hain, the mother comes. Can you tell me the timings? Deva, can you tell me the timings? Right? Hum gaate hain. At what time you started singing? Yes, it was 11. The mother came 11:30, right? And if there is a problem in between, it is alkaptonuria. It is the alkaptonuria. So the point is, in alkaptonuria, I can say this one will be more, this one will be less. So if I want to know that which metabolites are more, which metabolites are less, at the same time in a blood sample, I can do the tandem mass spectrometry. That will tell me about the various amino acid, which is more, which is less. And based on that, we can make a very early diagnosis of many disease and we can prevent the complications, right? The next is a toxin is metabolized intracellularly to a compound that condenses with oxaloacetate and subsequently inhibits the aconitase enzyme. So basically, they're asking a direct question that which toxin inhibit aconitase? This is the question actually. The remaining thing is just to confuse you. There are three inhibitors we have discussed in the Krebs cycle. There are three inhibitors we have discussed. The one we have discussed is malonate. Malonate inhibits which enzyme of the Krebs cycle? Succinate dehydrogenase. Malonate is going to inhibit succinate dehydrogenase. Arsenite is going to inhibit alpha ketoglutarate dehydrogenase. And fluoroacetate is going to inhibit the aconitase enzyme. So they're asking simple question. Aconitase is inhibited by what? It is inhibited by fluoroacetate. Iodoacetate is going to inhibit the enzyme in the glycolysis. That is going to be the glyceraldehyde 3-phosphate dehydrogenase. That we have discussed in the glycolysis. And these are the three we have discussed in the TCA cycle. So they're asking that fluoroacetate inhibits what? It inhibits aconitase. But now I have a question for you. Can you tell me that fluoroacetate sometimes can stop the glycolysis also? Which enzyme of the glycolysis can be stopped by fluoroacetate? The answer we already got, right? The answer to this is fluoroacetate, this question. My question is fluoroacetate can inhibit the glycolysis which enzyme? Because fluoroacetate contains fluoride. And fluoride can inhibit which enzyme of the glycolysis? Enolase. Enolase is inhibited by the fluoride, sodium fluoride, fluoroacetate. Fluorides can stop that, right? Can you tell me that fluoroacetate can lead to problem with the calcium also? Can lead to hypercalcemia or can lead to hypocalcemia? What do you say? Fluoroacetate can increase the calcium or can decrease the calcium. It can chelate the calcium and the calcium can be less. In fact, fluoroacetate can stop the electron transport chain also to some extent, right? So the fluoroacetate can stop multiple things, and one of them is the aconitis, which they have asked in the question. The next is a 10-year-old neonate presents with the progressive lethargy, recurrent vomiting, hypotonia, poor weight gain since birth. These things can be seen in many metabolic disorders in biochemistry. But what important they said was ammonia levels are increased. The moment this word will come, hyperammonemia, I will think that there is some urea cycle disorder is going on. In a newborn, the ammonia is more, means there is some problem in urea cycle. We know that there are 5 enzymes in the urea cycle, right? Now I have to find my keyword. And what was the keyword that was mentioned here was there is some problem with the hairs. Which urea cycle disorder will have the problem with the hair? That was the buzzword for us. It is going to be, the name of the disease is going to be the arginosuccinic acid urea. See, what happens is ammonia converts into carbamyl phosphate, that converts into citrulline, that converts into arginosuccinate, that converts into arginine, and ultimately urea. Now, here the enzyme that is there is, it is arginosuccinate lyase. And we have discussed that if there is a defect in the arginosuccinate lyase, this reaction will not happen. The arginosuccinic acid will increase and that will start coming in the urine. This disease is called as arginosuccinic acid urea. Arginosuccinic acid urea. And in this disease, we are going to have the hair defects. The moment they say hair defect in urea cycle disorder, it's arginosuccinate lyase deficiency. It was a classic question. Now, I want to tell you three buzzwords in urea cycle disorder. First, if they say hyperammonemia, can you tell me, along with that, there is orotic aciduria? If this word is mentioned, then the answer is which enzyme deficiency? Yes, it is a deficiency of ornithine transcarbamylase, the second enzyme. If they say hyperammonemia with hyperornithinemia, or instead of ornithinemia, they write gyrate atrophy. There is a problem in the retina. The moment hyperammonemia with gyrate atrophy is written, where is the defect? Yes, wonderful. It is a defect of ornithine transporter. It's a defect of ornithine transporter 1. Wonderful. Which is also called as which disease? Triple S syndrome. And if there is a hair defect is mentioned, we'll think of arginosuccinic aciduria. Hyperammonemia, super important topic. Yes, the urea cycle disorders. And these are the three buzzwords that will definitely will fetch you 1 marks in the exam. The next one. Which of the following statement regarding the physiological functioning of HDL is incorrect? Which is a false statement? This is what they're asking. Which is a false statement regarding HDL? I don't want to read the first 3 lines because my question itself, I'm getting the crux that he is asking the false statement. So let me read the option. If I'm not able to get the answer, then I will read the question in the exam. So the first option they are saying is HDL is serving as a circulating source of the apoproteins which is required for the chylomicrons and VLDL. See, the chylomicrons and VLDL, which apoproteins they require? They require ApoB48, C2, and E. VLDL requires ApoB100, C2, and E. And you know what? This C2 and E, these molecules actually comes from HDL. HDL has a capacity to generate ApoC2 and E, and these ApoC2 and E, once they are generated, they are donated here as well as here so that these two molecules can work. So HDL is serving as a source of apoprotein. Yes, it is a serving as a source of apoprotein, and which apoprotein it is producing? ApoC2 and E. This is a true statement. Second, scavenger receptors SRB1. They help in the selective reuptake of cholesterol esters from the HDL into hepatocytes. Yes, the SRB1 receptors are there on the HDL. Here is the bag of HDL, and it is having a special receptor which helps in the cholesterol uptake from the peripheral tissue. But there is one receptor, this name of receptor is ABCA1, that helps to take up the cholesterol from the peripheral tissue. From the peripheral tissue, we want to take up the cholesterol and we want to bring it to the bag of HDL. That is done by the ABCA1. But there is one more receptor that is there. It is the SRB1. And it facilitates the cholesterol esters from the HDL to hepatocyte to some extent. Not significantly, but yes, to some extent, the cholesterol esters can be directly transferred with the help of SRB1. But most of the cholesterol esters, they are not transferred via the SRB1. The cholesterol esters, we have the cholesterol ester transfer protein, which then we are going to transfer the cholesterol esters in the remnant of chylomicron, in the remnant of VLDL. We transfer these cholesterol esters, and these cholesterol esters will come back to the liver like this. So this is how the cholesterol esters are coming back to the liver. Most of the cholesterol esters will be transferred via the cholesterol ester transfer protein to the remnants, and then they come to liver. But some can go directly via the SRP1. Yes, they can go. They can go. This is also true statement. HDL participate in the reverse cholesterol transport? Yes, 100% true. HDL brings the excess cholesterol from the periphery to the liver. It's a good cholesterol. It brings the excess cholesterol back. HDL promotes the oxidative modification of LDL, the low density lipoprotein. Low density lipoprotein means HDL. They are saying that HDL is promoting LDL. No, HDL never promotes LDL. They are opposite. HDL is a good cholesterol, LDL is a bad cholesterol. HDL does not promote LDL. It is a false statement. It does not promote. Rather, it is going to stop. It is anti-proliferative. It is anti-atherogenic. HDL does not promote LDL. It is a false statement. You may be confused with these two statements when you are solving the paper, maybe B or D, because rest of the two, this everyone must have eliminated this option at least. HDL is participating in the reverse cholesterol transport. Everyone must have eliminated that option. You may have been confused with the B and D, but if you see the D option, that is saying that HDL is promoting LDL. No, that is for sure it is not going to happen. HDL is not going to promote LDL. This question would have been slightly easier instead of low density lipoprotein if the word LDL was mentioned, which is actually the same, low density lipoprotein. Then your eyes would have caught that thing. HDL promotes LDL. No, HDL does not promote LDL. If I remove this last option and I write like this, HDL promotes LDL. Is it a true or false statement? Then yes, you may have ticked that answer that this is a false statement, right? This is what is the same thing is written, but just in a different manner. Just to hide the LDL, I have written low density lipoprotein, so that your eyes will be diffusely scattered over the long options, and you are jumping from one option. By reading the one option, you go to other option and here and there, and we may have missed that small hint that was there. Now, this was a simple question. Which are the faults regarding non-competitive inhibition? Non-competitive inhibition, we have discussed that in the revision class, right? We have the competitive inhibition, we have the non-competitive inhibition, and we have the uncompetitive inhibition. We should know that what is happening with the Vmax, what is happening with the Km. In the competitive inhibition, you can compete with the toxin and you can reach to the Vmax. The Vmax will remain same, but the Km is going to increase. In the non-competitive, you can't reach. In the uncompetitive, you can't reach the Vmax. The inhibitor's effect cannot be removed. We can't reach the Vmax. But in the non-competitive, the Vmax remains the same. Here, the Km remains the same, but here the Km is going to be less. So what they're asking is, which is false regarding non-competitive? The maximum velocity of the reaction is reduced. Yes, the Vmax is going to be reduced. This is a true statement. The Michaelis maintained constant is going to be reduced. The Km, Michaelis constant is the Km actually. The Km is reduced. No, Km is going to be the same. This is a false statement, but still read the other option. The inhibitor interacts with the enzyme outside the active site. Yes, in the non-competitive inhibition, what happens is, for example, here is the enzyme. On the enzyme, we have two sites, the active site, and here is the allosteric site. Normally, the substrate is going to attach on the active site. It will fit in the active site. Now, in the non-competitive inhibitors, what they do is they don't attach on the active site. Rather, they are going to fit in the allosteric site. Once they fit in the allosteric site, they change the shape of the active site. And if you change the shape of active site, now the substrate cannot attach. And this is how the non-competitive inhibitor is working. So they're asking that the inhibitor interacts with the enzyme outside the active site. Yes, true. It is the allosteric site. The substrate binding to the enzyme is not directly prevented. Yes, it is not directly preventing. The non-competitive inhibition is not directly preventing that. It is also a true statement. So what is the false? That Km is going to be reduced? No, Km is going to be same. Which of the following supplement is most likely to improve the underlying metabolic defect? A 9-year-old child presenting with progressive myopia, the inferior displacement of the lens, that is ectopia lentis. A child is presenting with ectopia lentis. There's long cylindrical arms are there, long cylindrical fingers, that is archinodactyly. The history of recurrent DVT, the moment I will see this DVT word, now I have made my diagnosis, right? The moment you see marfanoid habitus plus DVT, the answer is clear. It's hyperhomocystinemia. Hyperhomocystinemia. This patient is having more homocysteine. Actually, what happens is the homocysteine can convert into cystathione. And to convert into cystathione, we require the cystathione beta synthase enzyme. And that requires vitamin B6. There is one more option is the homocysteine can convert into methionine. And for that, we require the vitamin B12 and B9. So this is the two ways by which you eliminate the homocysteine from your body. These are the two methods by which we remove the homocysteine. We convert into cystathione or methionine. But now what they have said is there is homocysteine is more, but without evidence of megaloblastic anemia. There is no megaloblastic anemia. Means the B12 is normal. Means this reaction is happening. Definitely, then if this reaction is happening and despite that the homocysteine is more, means this reaction must not be happening then. Either of the reaction should have a problem. And because they have said there is no megaloblastic, so I would say the first reaction must not be happening then. And there is a problem in the vitamin B6 will be there. If there is a vitamin B6 deficiency, the homocysteine will increase. So by giving which molecule, the things will return to normal. It is going to be pyridoxine. Which of the following enzyme directly catalyze the reaction? Now, during the prolonged fasting, amino acids are increasingly utilized for energy production. In the hepatocyte mitochondria, the nitrogen from multiple amino acid is first funneled into glutamate via transamination reaction, and the final step will liberate the free ammonia to enter in the urea cycle. Now, what is the meaning of these 4 lines? Let me draw a simple diagram for you. What they are saying? They are saying that whenever we are having the amino acid, because when we are in the fasting state, we start using muscle protein. When you cut the muscle protein, you get amino acid. When you cut the amino acid, you get ammonia. And this ammonia, we need to convert into urea. And this conversion only happens in the liver. Now we are having the different amino acids. They should donate their ammonia to the liver. But actually, you know what? There is only one amino acid which is ready to give the ammonia, and the name of that is glutamate. The glutamate is ready to give the ammonia. So what the muscles will do is, because the other amino acids are not giving the ammonia directly to the liver, so the muscle will convert the different amino acids, different amino acid into glutamate. That is called as the transamination. And then the glutamate will go in the liver and will donate the ammonia. If you remove the ammonia in the liver, this is called as the oxidative deamination, which we have discussed as the step number 2 of biosynthesis of urea, oxidative deamination. And in oxidative deamination, we also have discussed that NAD converts into NADH. And whenever the NAD, NADH comes, what is the name of enzyme? This is what they're asking, that glutamate converts into ammonia. What is the name of enzyme? Here it is written that in the final step, the free ammonia is coming out, which is going to enter in the urea cycle. The ammonia is coming out, which is entering in the urea cycle. This ammonia will enter in the urea cycle. So they're asking that in oxidative deamination, what was the name of enzyme which was making the free ammonia? And the answer for that was the glutamate dehydrogenase. Glutamate dehydrogenase. Again, it was a trap of the language, right? It's a complete trap of the language. If I would have asked the same thing with a different language, most of you would have given a correct answer, right? And this is what happens in the examination hall also. When there are two types of feelings that comes in the examination hall. When we are reading the question, the first feeling that comes is that key while reading the question, oh, I know this topic, I know this topic, but when I look at the option, I have never seen these options. The second feeling that comes is when you are reading the question, the first line, second line, yes, 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 I know, urea cycle. And then the third, fourth line, it's gone. What he is asking. I was happy with when I was reading the first two lines. It's from urea cycle, the topic which I have studied, but now it's completely out of the box, out of the context. Actually, they're asking the same concept, but with a different language. Because the point is, the teacher who has taught you in the class, he has to teach you in simple language. Then only you will understand, right? And the one who is making the paper, he is the enemy of you. He has to make a paper in a language which you can't understand. So there is a language gap that is being created. It's by default that has to be there, because if just imagine that in the class, if I have explained you the biosynthesis of urea in this language which is written in the question, you would have never understood that. So I have to explain in simple language. I can't use this particular language there, right? And the examiner will most of the time will use that difficult language. So that bridge will be corrected while solving the question. That is the purpose. One of the purpose of solving the question is to create that thought process that in what context the question has been asked. To वो पूछना क्या चाह रहा है? This is what we want to learn out of that. That what exactly the examiner is willing to ask. So, and those who are preparing sincerely, right? This is one element which is making a big difference in the ranks. That despite knowing the concept, while reading the question, we are unable to fetch out that what exactly he's going to ask. So when you are reading the question, when you are solving the MCQs at home, when you are giving the GTs, don't just give the GT or the test for the sake of marks. That last GT I got out of 200, 130. Now this time I want 140. No, that should not be the goal. The goal has to be that whether I'm able to get the context in the timed manner, in a limited time frame, whether I am able to get the context that what examiner is asking or not. This is what is more important. Marks automatically follow. I know that eventually it is the marks which matters. That will automatically come if you will work in the concept part, in the reading of the MCQ part, uh, uh, in the the meaning of the question, understanding the context, then automatically the marks will follow. The underlying defect most directly impairs which of the following metabolic process? Which metabolic process is not happening? A 3-month-old infant presenting with hypotonia, refractory seizures, there is some problem with the brain, poor feeding, failure to thrive, the milestones, dysmorphic facial features, hepatomegaly, diminished deep tendon reflex, there is some problem with the brain for sure. MRI shows cortical atrophy, delayed myelination, and many things were there. But the main hint was here. There was increase in very long chain fatty acid. This just one word has given me the answer. What happens is very long chain fatty acid. Normally, the fatty acid metabolism happens in the mitochondria. Normally. But very long chain fatty acid cannot enter in the mitochondria because they are too big. So very long chain fatty acid metabolism occurs in which organelle? Peroxisomes. The very long chain fatty acid goes there with the help of the enzymes in the peroxisome. We are going to break it into small one. And by chance, if these enzymes are defective, then very long chain fatty acid will accumulate, will damage the peroxisomes that is there in the brain, liver, and kidney. This is called as what? This is called as the Zellweger syndrome. Also called as the cerebro-hepatorenal syndrome. There is damage to the brain, there is damage to the liver and kidney. cerebrohepatorenal. In fact, the moment you see this word in any MCQ in your exam, very long chain fatty acid, one of the first differential that definitely should come to your mind is Zellweger. It may be Zellweger, right? So they're asking that, what is the problem with the Zellweger? Is it the mitochondrial beta oxidation which is problematic? No, the very long chain fatty acid, anyhow, they are not going in the mitochondria. Is it the problem with the carnitine dependent transport? The carnitine dependent transport is found in the mitochondria, that is CAT. Very long chain fatty acid, anyhow, they are not using the CAT. They are not using the CAT. Is it the alpha oxidation? No. Alpha oxidation is related with which disease? Refsum disease. If you remember, Refsum disease, the green leafy vegetable, that is alpha oxidation. It is the very long chain fatty acid oxidation, which is not happening in the peroxisome. The hydrogen peroxide producing oxidation is not happening in the peroxisome and creating the problem. Right? It is the Zellweger syndrome. A 19-year-old woman, poorly controlled type 1 diabetes, polyuria, vomiting, abdominal pain, progressive drowsiness. The moment you see a type 1 patient is presenting with these symptoms, the vomiting, abdominal pain, it is most likely going towards diabetic ketoacidosis. If a type 1, because in type 1 diabetes, DK is very common, diabetic ketoacidosis, and they are presenting with abdominal pain and vomiting. You can see the fruity breath of water is also mentioned. It's clearly it's going towards DK. The ABG is showing metabolic acidosis. So I was pretty much sure that it is diabetic ketoacidosis. And they have mentioned that the ketone bodies are also increased. The beta hydroxybutyrate is more. Which of the following enzyme is expected to show increased activity? Means in diabetic ketoacidosis, we know that the ketone bodies are more. And to make the ketone bodies, the rate limiting enzyme of ketone body synthesis should work more. And what is the rate limiting enzyme of the ketone body synthesis is there? It is the HMG-CoA synthase. Simple question. They're asking that which enzyme must be working more, because this patient is having more ketone body. So the ketone body synthesis enzyme will be must be working more. That is the HMG-CoA synthase. This was simple question. Not at all difficult. What is the special molecule? Tyrosine is making the thyroid hormone. Tryptophan is making the serotonin. The first is B, second is going to be D. The glycine is helping in the synthesis of creatine. Actually, creatine is made up of 3 amino acids. If you remember, GAME, glycine, arginine, methionine. So B, D, A, B, D, A. I got my answer. B, D, A. Even you were not knowing any of them. Even just one, you were knowing that tyrosine, the thyroid hormone is made by tyrosine. Even you were knowing that, you would have got your answer, right? We don't have to do the others. Nothing. Because there is only one option that was showing 1B. There is no other option. Which of the following apolipoproteins is essential in activating the enzyme responsible for this reaction? Now, what they are saying is that a 46-year-old man, strong family history of premature coronary artery disease, undergoes lipid profile. The HDL cholesterol levels are significantly reduced. The HDL is less. The further evaluation reveals the impaired esterification of the free cholesterol. Now, what is the meaning of esterification actually? See, the cholesterol, when it is there in the peripheral tissue, when you want to bring it back to the liver, you send the bag of HDL, if you remember, the empty bag of HDL, it will go there and it will try to take up the excess cholesterol. When the cholesterol is filled in the bag of HDL, this cholesterol is supposed to convert into cholesterol esters, because we want to convert the liquid cholesterol into solid cholesterol so that we can bring it back nicely. And this cholesterol ester filled HDL is called as the mature HDL. To convert the liquid cholesterol into solid cholesterol means the esters of the cholesterol, we require the enzyme alkate. And who activates the alkate? It is the ApoA1. ApoA1 activates. So they're asking that the liquid cholesterol is undergoing esterification, that is the cholesterol esters, liquid cholesterol to cholesterol ester. Which enzyme is required? Alkate. Who activates the alkate? ApoA1. ApoA1. The next question. This was a more of a straightforward question, that which of the following combination correctly identify the fatty acid which you cannot synthesize? They're asking that which are the essential fatty acids? Essential fatty acids. A student is preparing a diet plan identifying the fatty acid that must be taken from the diet, because the humans cannot make that. The enzymes are not there to make that. Which are the essential amino acid, essential fatty acid? The linoleic acid, alpha linolenic acid. These are the essential ones, second and fourth. Arachidonic acid is a semi-essential one. This is a non-essential. So the essential is 2 and 4. And if I ask you, this was asked in the INI CET recently, which is the most essential? The most essential is linoleic acid. So these two are essential. And if they ask that which is the most essential, it is the linoleic acid. Linoleic acid.